we stay in the same topic, and I'm going to present you our protocol for fast-track robotic partial nephrectomy with a discharge at J1. First of all, we have published in 2014 our first cases of nephrectomy, and we say, what about partial nephrectomy? So, 3R protocol. What is 3R protocol? It is a fast-track robotic partial nephrectomy program. R for robotic, R for renal, RAC. In English it is ERAS, in French is RAC. We started this program in February 2015, and we have included roughly 160 patients. Just to remind, before our 3R protocol, in 1 week, in one bed during a week, we had 1 patient, and now we can have until 4 patients in one bed during a week. So, first step, you have to convince your department that 3R protocol is very useful for your patients. So you have to organize several meetings with everyone, surgeon, of course, your colleagues, nurses, physical therapists, assistants, and especially anesthesiologists. The second step is that you have to convince your patients. We show this picture at the consultation, and we explain them that you have to prepare for your race. Your race is your operation, but they don't have to be worried about that. So you have to explain them that it is for their own interest, because they will have less post-operative complications. So for the protocol before hospitalization, they have to stop smoking 4 weeks before, stop alcohol 4 weeks before, renutrition systematically, and they have to a physical activity, for example, going for a walk every day, and we give them the protocol. Before the surgery, the day before, they have to drink 1 liter of apple juice, and the day of surgery, they can have clear fluids up to 2 hours prior to surgery. Of course, no solid foods from 6 hours before the operation, and our nurse will have to give last explanations. The most important is to give explanation again and again and again. The day of surgery, patients will be admitted in our surgical admission lodge. It is like Air France, it's the same. Patients will come to hospital on the morning of surgery, and they have to walk up the operative room. You need to perform a mini-invasive surgery. So in 3R protocol, it is a robotic partial nephrectomy. It is useful because it is a mini-invasive, painless procedure. Mini-invasive procedure allowing early mobilization, little scars, and moderate pain. It is a mini-invasive procedure because they don't have an urinary catheter. No drain, no morphine, and no PCA, and no hydration by perfusion during the surgery and after the surgery. When they arrive in the departments, they only have one catheter in each arm. At day 0, at the arriving in the department, they have early mobilization and getting out of bed. So they will have first steps with our physical therapist. Collation in the afternoon with a yogurt, no restrictions on drinking. In the evening, they have a normal alimentation. They get dressed. It's so important, so they feel less ill. Pain control with ketoprofen. Morphine, it's absolutely forbidden. Discharge at the day after the surgery at 11 in the morning. scars without bandage. They had an hemoglobin and a creatinine at 6 a.m. because we can check that there is no problems with that. And our physical therapist will be with a last time with our patients for climbing stairs. We give our patients emergency number, and the day after, our nurse will call them. As you can see, we dramatically decreased our length stay. In 2012, we were 4.9 days, and we have two steps in 3-hour protocol. In 2015, it was a discharge at day 2, and since the beginning of this year, it is a discharge at day 1, and our mean length stay has decreased at 1.9 days. We have a follow-up, and it's so important. We have a database, and we have a monthly meeting in the urology department. It's so important. See, for example, if we have a patient who have a discharge at day 3, we try to understand why. So we give to the patients a ERTC questionnaire. It is a questionnaire for evaluation for a medical doctor, nurse, quality of care and department, and general evaluation. Our rehospitalization rate for our first patients, 7 patients came back to the hospital, and the rate is relatively low, 5.83%. Causes of failure of the implementation of such program. First of all, it is a lack of explanation. Lack of explanation to the patients, lack of explanation to the family doctor, to the staff. So you have to explain and explain and explain. It's so important. Absence of teamwork. When you have temporary employees during the weekend, it's a real problem because they don't know about the protocol. The weight of habits, the reticence by some anesthesiologists of fluid intake 2 hours before the surgery, fear of complications at home, and resistance to change. Next step for 2018, it is a robotic partial nephrectomy in an ambulatory setting, maybe as a standard of care. For your information, you can find on the Intuitive booth a memory stick with all our protocol. The protocol is in English and in French, and I put inside the patient's brochure. So, of course, you are welcome to Lyon Sud when you want, and I give you my email address. Thank you for your attention.
So it's a sponsor session by Intuitive. Usually we don't ask questions, but perhaps for this very important topic, we can take some time to have a discussion concerning this fast-tracked hospitalization. Do some of you use this kind of procedure? I mean, yes, Discharge Hospital at D0 or D1? Raise your hand. Yes. So, are you happy with that? Yes, yes you are. Okay, and the patient?
Well, I work also in Stockholm with Peter Wiklund, and they're Vikings, so it's okay. They're absolutely fine. We have no problem.
Scandinavian knows this subject very well because Kellett, who described this protocol, he started, I think, at least 20 years ago. So we are a bit late in France.
Yeah. Okay. Question or comment? Yes.
Thank you. Do you often need to go to CT scan before discharging the patient if you have a hemoglobin at day one who is low, or if maybe you feel there's a problem?
If we have one problem, we don't allow the discharge. So if there is a problem with hemoglobin, our patient will stay one more day in the hospital. And of course, if there is a big problem, he will have a CT scan.
How do you select your patient? Are all your patients candidate for this kind of approach, or you really select the patient with, for instance, exophytic tumor with an easy case?
So all our patients have now the protocol for a discharge at J1. Every patient, because if you say at the consultation you will have your discharge at day 2 or day 3. If they are feeling very well at day 1, they will be very worried to leave the hospital. So roughly 60% patients can have a discharge at J1, and sometimes the discharge is at J2, J3, J10 when you have a problem.
Okay, I'm going to ask the question the other way. So when do you exclude, and which patient do you exclude for this program? You say it represents 60% of the case.
The inclusion is for all patients. But if when the day after it seems that there is a bleeding or there is a problem, there is nausea, so we explain to the patients that he can't receive the perfect protocol, and he stays with us.
Okay, so thank you very much, Philippe, for this nice presentation. I suggest that we go back to the OR. Now I'm going to ask the different moderators to come on the podium. And I think we'll go to Montsouris Hospital.